Thank you very much, David. So I'm going to wrap it up in the next 15 minutes and look at, what are new and emerging conditioning regimens. So again, I think the theme of our field has been, how can we cure hematologic malignancies by exploiting two strategies? The first one, which was the one that actually developed the field, was the possibility of eliminating resistant malignant cells by increasing the dose of physical and chemical agents, be it alkylators or radiation. Now we have to recognize that there are some malignant cells that simply will not respond to dose-intensive therapy. The second, which was initially proven, I would say statistically many years ago by this seminal paper from the CIBMTR with Mary, that there was a graft versus tumor effect. Now I remind you that at this time, most of the transplants we were performing was for chronic myelogenous leukemia. And in that situation, it was clear that having HLA disparities and having T cells would result in a significant reduction in relapse, that both syngeneic transplants and T cell depleted transplants were associated with a significant graft versus host disease, but that we could separate a graft versus host disease from a graft versus leukemia phenomena. However, data from CD34 selected grafts, when we compare it to MD Anderson and MSK data, has shown that at least for acute myelogenous leukemia, the increased risk of relapse that is associated with T cell depletion is not seen. So the yin and the yang here, and as you've just seen from both David's presentation and Bart's presentation, is that we can reduce non-relapse mortality by reducing the intensity of the regimen and relying on graft versus leukemia effects. But we pay a price by increasing risk of relapse. And the question comes up is, are there strategies that we can explore today that will allow us to exploit the dose intensity without increasing non-relapse mortality? So why do we want to try to continue to improve the conditioning regimen? Because have you seen in all our transplant curves, there seems to be two populations of relapse. Patients that relapse early, shown here in the oval marked A, and patients that relapse late, shown here in ovals marked B. And one can assume that the mechanisms of disease resistance for these two populations are intrinsically different. And as we saw in the presentation by Dr. Vigo, you could think that those that relapse late are patients whose leukemia can escape the graft versus tumor effect, either by loss of HLA, development of or increases in checkpoint blockades in both the leukemia and the lymphocytes, or eventual escape by losing targets for a graft versus tumor effect. However, those patients that relapse very quickly after the conditioning regimen are probably patients whose leukemia are resistant to the physical agents and chemical agents that were given as part of the conditioning regimen. And we and others have postulated that the mechanisms of prevention of relapse for these both populations are probably different. That for patients who are, for late relapses, the use of maintenance therapies or immune modulatory strategies that enhance the graft versus tumor effect are essential. But that for patients relapsing early, modifications of the conditioning regimen and early interventions will be essential. So the best way that we can improve outcomes is actually early referral. Unfortunately, there's things that are many times out of our control, and early referral may not help us with patients with primary induction failure, which still represent about 30 to 40% of patients with acute myelogenous leukemia or myelodysplastic syndromes. There are new graft sources that have been potentially associated with lower relapse rates. And I particularly point out patients and donors who are C2C2, in which the results of 10 out of 10 match-related or unrelated donors have consistently shown a very high relapse rate. And we and others are exploring the use of alternative donor sources, either looking at cure-advantaged donors or cord blood versus haploidentical. However, we want to focus on trying to improving the conditioning regimen, which is the one strategy which we think can allow us to positively affect and eliminate cells that could be potentially resistant to these agents. How can we do that? I mean, we've already seen some evidence of places where we should explore. The data of increasing the doses of TBI or increasing radiation as a strategy to reduce relapse has at least been shown to be effective in ALL. Unfortunately, in myeloid leukemias, external beam radiation can reduce the risk of relapse, but at the expense of increased non-relapse mortality. In the setting of primary CNS lymphoma, the addition of thiotepa has actually improved outcomes when compared to the traditional busulfan cyclophosphamide conditioning regimen. Cyclophosphamide VP16 TBI in ALL has been associated in retrospective analysis to be with less relapse rates. I think more interesting is, can we add some targeted therapies to our conditioning regimens and increase anti-tumor kill without increasing relapse rates? And some examples are gemtusumab ozigomycin, inotuzumab, iomab, which we'll talk about, and Rituxan. And the ability to even optimize the way we're delivering drugs today. Well, I'll talk to you a little bit about PK-directed therapy with intravenous busulfan. So Bart already spoke about this, and I think I underscore the fact that dose intensity, at least in AML, is very important. And when you compare the outcomes of just a 50% reduction in the dose of busulfan, you end up paying a significant price in relapse. So how can we optimize busulfan? The group at MD Anderson, Dr. Bori Anderson and Dr. Richard Champlin, have pioneered the use of PK-directed conditioning. Last year, they reported their outcomes in the Biology of Blood and Marrow Transplant. So by adjusting the dose of busulfan to try to get an optimal exposure of 6,000 micromolar per minute, they were able to show a significant benefit in event-free survival, less in patients who are remission in transplant, but much more in patients who have active disease. I want to focus on the issue of radiation. We do have evidence that if we could significantly increase radiation exposure of malignant cells, we will significantly improve outcomes by reducing the risk of relapse, particularly the risk of early relapse, which is particularly important for patients who are coming in with active disease, which represents for us today our major challenge. So I remind you, going back now to more than 20 years, a seminal observation that was made in the group of Seattle when they randomized patients to receive either 15.75 gray of external beam radiation versus 12 gray. Significant reduction in the risk of relapse, but as a significant increase in non-relapse mortality. And this study actually put a big note of caution for all of us who wanted to explore low dose intensity, because you're talking about almost a tripling in the non-relapse mortality rate. So for many years, we've tried to develop strategies that would allow us to deliver high doses of radiation to the tumor bed rather than to the whole body. Why would we want to continue to try to explore radiation? You've seen the data. Increasing radiation dose intensity is an effective way of reducing relapse. Leukemias and lymphomas are highly radiosensitive, but as we've seen, with current technology, giving total body radiation could not be safely dose escalated. Now, mind you, immodulated radiotherapy or like maybe a way of getting straight to the marrow and giving high doses to the marrow. We saw that yesterday. But there may be other ways of delivering high doses of radiation directly to the tumor bed and sparing normal tissues. So one of the ways that we explored at MD Anderson was actually chelating or using a chelator as a way of delivering a radioisotope directly to a bone marrow space. So this was holmium DOTMT trial. So DOTMT is a chelator. It goes to the calcium and phosphorates in the bone marrow space. When you conjugate it with a radioisotope, you have a way of delivering very high doses of radiation straight to the marrow space, and particularly to areas of remodeling bone, which myeloma does. So holmium is a high-energy beta emitter. DOTMT is a tetraphosphonate. So the conjugation of this allowed us to deliver very high doses of radiation to the bone marrow space, and this was called targeted skeletal radiotherapy. So we did a phase 1-2 study. We were able to deliver very high doses of radiation, up to more than 1,230 millicurie per meter squared. And initially, we were very pleased. We were getting very high rates of complete remission. But at the 9-month mark, we started having patients coming in with hypertension and increased creatinine and a picture that looked like thrombotic microangiopathy, essentially the same as radiation nephritis. So other ways that we have tried to explore delivering high doses of radiation through radioimmunotherapy was the use of the radioimmunoconjugate tositumomab, which was a CD19 conjugated to an iodine, to a radioisotope, delivering very high doses of radiation to areas of potentially tumor burden. This was the randomized CTN trial, which unfortunately did not show a benefit for the combination of tositumomab beam versus rituximab beam. So are there other ways to exploit radioimmunotherapy? So John Pagel and the group in Seattle pioneered the use or the exploration of the CD45 antigen as a way of delivering high doses of radiation to the bone marrow space. CD45 is a tyrosine phosphatase. It's surface stable. That means it's not modulated, and it's expressed on virtually all leukocytes at a very high copy number per cell. And 85% to 90% of acute leukemias express CD45, and more importantly, it is not present in non-hematopoietic tissues. So John Pagel and the group in Seattle conjugated iodine-131 to CD45 and developed a conditioning regimen that would deliver high doses of radiation into the marrow space. Patients that were eligible were more than 50 years of age, not candidates for a standard transplant, no other curative strategies. The radiation dose was calculated to the normal organ receiving the highest dose, which was the liver. Initially, they would escalate a dose in 2-gray increments until they had their first dose-limiting toxicity, and then they would go 4 by 4. They were able to give a total of 12 to 26 gray to the bone marrow. The estimated MTD was 24 gray. So they would do a test dose, and according to the test dose, they would decide what the dose would be to deliver the desired dose to the liver. And then 10 days after giving the treatment dose, they would give a reduced intensity, a truly non-ablative conditioning measurement with fludarabine and low-dose TBI, and then peripheral blood stem cells, followed by graft versus host prophylaxis with cyclosporin and mycophenolate mofetil. So in patients greater than 50 years of age, they were able to deliver 33, a mean dose of 33 grays to the bone marrow and a mean dose of 101 grays to the spleen. This is the mean, dose of iodine-131 injected to deliver. Remember, this is a personalized medicine. They calculate the specific dose to get a specific exposure in marrow and spleen while protecting the liver. And this is the data we have from the 58 patients with active disease. Non-relapse mortality rate relatively low at 20%. a relapse rate at 40%, with this now long-term follow-up with about 20 to 30% of the patients achieving long-term disease control. Remember, these are patients with active disease where the relapse rate is expected to be almost 70 to 80%. So again, this is the patients receiving the maximum tolerated dose of 24 gray to the liver, a relapse rate of approximately 30%, non-relapse mortality rate of approximately 20%, with overall survival and disease-free survival at 3 years approximately 40%. I think we would all agree that for patients with active disease, these are very good results. So this has led us to now do a multi-center pivotal phase 3 trial, which we call the Sierra trial, which is a study of lomab-B in elderly relapse refractory AML. This is a phase 3 open label randomized controlled trial. Patients have to be over the age of 55. And the randomization is as such. Patients are randomized to either get conventional chemotherapy or to get iomab, fludarabine, low-dose TBI, as shown in the phase 2 by the group in Seattle. The primary endpoint is actually achievement of a complete remission. This is a design that we were able to tell the FDA that the real endpoint here is achieving a complete remission. Patients in the control arm are actually not excluded from transplant. If they achieve a complete remission, they are allowed to get a reduced intensity conditioning regimen or allowed to be observed. The overall primary endpoint is 6 months CR. So we think this is a very important study. We're expecting 150 patients over a period of 2 to 3 years, and we hope that this will provide, we would say, the first licensed strategy to treat effectively patients with active disease at the time of transplant. There are a lot of logistical considerations. The most important one, and this is very important for patients with active disease, is that we need early HLA typing of AML patients so we can rapidly find a potential donor. Remember that in 2017, with the advent of cord blood registries, the increase in the unrelated donor registry, and the use of haploidentical transplants, everybody has a donor. So in summary, long-term disease control is possible for patients with relapsed refractory AML. Patients with primary refractory AML should be considered for transplant as soon as possible without further attempts of reinduction. All patients with relapsed acute leukemia should be considered for transplant on investigational protocols. And to be able to get patients with refractory relapsed acute leukemia rapidly to transplant, it's essential to early HLA type all AML patients and their family members and involve the BMT team in the care of newly diagnosed patients so that a donor can be rapidly identified in the case of refractory disease. Thank you very much for your attention. I would like to call my co-faculty to the up front so we can go for the Q&A session.